So I want to introduce Madam President, Saroni.
Welcome parents and teachers to our opening town hall meeting for 2021. These past few months have been hard for us, but I want you to know that we have been thinking forward and ahead, and we are going to be Montessori strong, and we are very blessed that we have Dr. Canody here, and Baycare has been guiding us to make our schools safe, not only for us, but for all our families, our teachers, and everybody, and so we can have, and most importantly, our children, so we can have a successful school year. So I'm going to ask my husband to take over now.
So I just want to create some ground rules. One, please mute your microphones. I'm recording this presentation, so we will make it available to those families who are unable to attend. If you have any questions, I've got a team that is monitoring it through chat. So please type in your questions so we can monitor it and take it from there. So I want to introduce Dr. Christina Canody, and we are just absolutely delighted that she has chosen to and agreed to join us to share her wisdom. She is a seasoned pediatrician, has been a pediatrician for over 22 years, 16 of them with Baycare in this area. So I'm going to turn it over to Dr. Canody, and she's going to make a brief presentation, and we'll throw it open to Q&A. We've got a tight schedule, so thank you for your consideration. Dr. Canody, the floor is yours.
Thank you very much. I'm glad to be here with you all this evening. And I know that everybody has had a lot of anxiety towards the opening of schools in the light of COVID-19. We're all facing a pandemic, which for all of us in our lifetime, this is the first time we've ever dealt with that. So I can tell you that everybody has your students and children's interest at heart. And we're doing our best to get the education out there and to help you know what to do in those situations to do what's best for your child. So just a little bit about myself. I graduated from the West Virginia University School of Medicine and did my residency here in Florida at the University of South Florida and All Children's Hospital. I've been practicing pediatrics in the area for over 20 years and continue on as a assistant professor at USF for pediatrics and have residents that rotate with me in my office at all times. I've been employed by the Baycare Health System since 2016, but I've been on staff at St. Joe's Children's Hospital since 2001. And 2 years ago, I assumed the role of the Pediatric Service Line Medical Director. So I actually oversee all the pediatric programs in all 15 of our hospitals, as well as our outpatient clinics, our quality programs. And then I also carry additional roles of overseeing our mobile medical clinic, our clinically integrated network. I serve on advisory boards to other facilities in the area. And then I also recently have assumed a role to assist with graduate medical education, including residents. Just to rehash a little bit what we know so far about COVID-19. What's important to know is the transmission routes. Respiratory droplet is the main way that this virus is spread. There are other body fluids that it's been found in, such as in stool, also rarely in amniotic fluid, sometimes in the blood, and also in brain fluids. But respiratory droplet by far is the predominantly way that this is transmitted from person to person. We know that there are particular vulnerable populations, and especially those living in highly populated areas, it passes pretty readily within a home site setting or also in large groups of people. And that's part of the reason that we've taken community recommendations for trying to keep smaller groups together and also to take precautions when you go out into public. Demographically, we know that older age also puts you at higher risk for severe infections as well as complications of this illness. And we also know that certain underlying genetics as well as health conditions also put you at increased risk. So those include chronic heart disease, chronic lung disease, diabetes, also seems to be disproportionate in certain ethnic populations, including individuals who are Black or other ethnic minorities. Some of this disparity is based on accessibility to healthcare and also increased risk of chronic disease. but we know in general, we also see a disproportionate risk seen based on what we've experienced so far in the United States. What's interesting is we have very little information, but we have a lot knowing that this virus was new to us and we only have experience with it for about 4 months in this country. But people are working together to try and find a vaccine as soon as possible and also to understand how to prevent its spread. Risk for spread, as I already said, is in dense areas where people are not taking precautions to prevent their spread. And some of the things that we have seen, and we've attested to this, when our state opened up beginning of June, within about 3 weeks, we saw great increases in those numbers. We think that's really due to the lack of social distancing and people not taking precautions to prevent the spread. I'm happy to report that the last 10 days, we've actually seen an overall decrease in our state numbers, especially in this part of the state. And that's encouraging as we move into the later summer months and into the fall, and hopefully get back to safe reopening of our schools. Other things that you need to know as far as the differences in age groups. In general, newborns seem to do very well with this infection. We see very little transmission to newborns after delivery. And in children less than 10 years of age, the majority of those infections are all spread from people in their household. So I would say over 85 to 90% of the infections that we see in children under 10 are from household contacts. Rarely it can spread from child to child, but in general, if we take precautions, then we can eliminate 85 to 90% of that spread. In adolescents or in children over the age of 10, they actually act a little bit more like adults when spreading the virus. So it's even more important that they practice social distancing and other factors that can decrease their risk of spreading the virus. I wanted to share with you the current data, and this actually comes from the Florida website that I'm sure you've all seen on multiple news reports. Currently in the state, this is total statewide results as far as all of our numbers go. And here overall, we have about 25,000 cases in children under the age of 14 combined. If you go, and then you can also see that the new cases day by day, it looks like it's relatively stable here, but this is related more to statewide and doesn't show exactly our area. I'm going to take you on to the next slide, which is Hillsborough County. And one thing to see is, number one, they're measuring 50,000 here. We were looking at 50,000 for the state. And then here also looking at the numbers, this goes 5 to 20,000. And the Hillsborough County data also does about the same. In general though, overall, our cases in Hillsborough County only make up about 12% of pediatric infections under the age of 15. So this is actually reassuring to us and makes some difference based on what we're seeing. We can tell you that the area in Miami-Dade and surrounding counties on the southeast part of the state make up over 40% of the pediatric infections. And if you take the 5-county area, including Pinellas, Polk, Pasco, and Hillsborough and Manatee counties, we only make up about 20% total of pediatric cases. Overall, I did share that the data looks like in the last 10 days, especially in our health system, we're seeing an overall decrease in cases. I know that there continues to be high numbers throughout the state, as well as increase in the death rate. However, this is related to ongoing infections and people that came down with the illness within the last several weeks. Overall, we've had about 1,500 pediatric patients under the age of 18 test positive for COVID-19 in our health system. That's significant because of those 12,500 I talked about in Hillsborough County. Our health system covers the 4 major counties surrounding us. But additionally, we're only testing patients who are symptomatic. because of the limitation of testing. So in general, we see about 8 to 10% of those pediatric tests positive, and this is gradually decreasing from a height of about 12% when we were in the early days of July is where it really increased. Overall, we saw a 200% increase in cases starting in the 3rd week of June. And those increased steadily until about 10 days ago. And now we've seen them cut back about 70% of what they were in early July. So those are all promising statistics that we're seeing change. And we hopefully think this is because people have decided to go ahead and follow all those safety parameters that we've tried to get the information out there that you can do to protect your family. One thing that's important and part of the consultation that we've done with the schools in the area is understanding in pediatrics, there are special needs for children that are not just served based on an education, but their social and emotional development really depends on being back together in an in-school setting. This statement was actually released from a collaboration between the American Academy of Pediatrics, the superintendents of the schools throughout the country, as well as the National Education Foundation. And basically what it says here is that we understand that we all share a common goal of children returning safely to school. All the organizations were committed to do everything so they can have the opportunity to safely resume in-person learning. Children really do learn best when they're physically present in the classroom, and they get benefit from those social and emotional developmental skills that they see there. Also added into that, and this is one of the public concerns that we have, there's a lot of children who have food insecurity and have other needs that help when they can return to school. I know that in your school, there are these special needs are changed a bit and probably don't apply to most of the kids going to school there. But in general, as a pediatrician in the community, it's important that we look as the area as a whole and understand that this is really hard on some of the families. I have a mom in my practice who is a teacher in an underserved area, Tampa, and she expressed to me that they actually feed breakfast, lunch, and dinner to their students at their school. They have dinner before they go home. And so over the summer, she's made an effort to go and find some of her students and make sure that they have food. And she was unable to find some of them, and there were others were living in motels and others living in their cars. And so some of those social disparities are some of the reason that we really are trying to get to a place where it's safe for everyone to return to in-person school. As part of the consultation that we did with Baycare, it included several members of our corporate team, and we went through your school with your administrators, looked at the layout, looked at what would be applicable ways that kids could enter the building, leave the building, ways that they could be staggered, ways that they could promote social distancing, and really make it safe to reduce the risk of viral spread from child to child. This includes the way that they sit in the classroom. So we want all the kids facing forward. This makes sure that they're social distancing and have several feet between their seats. And then also this includes educating everybody about the risk of spread and ways that they can prevent it. And so part of this plan, as we went through, we spent time via Zoom meetings, and part of our staff came into the school and reviewed some of the guidelines and everything there, and were able to answer questions from your staff and administrators. The things that you can do to help your child in general, practice social distancing and things that keep your family safe no matter where you go. Part of going back to school and understanding that school may be the least risky thing that you do in your life. In general, I'm around patients that have COVID-19 on a daily basis. So I take those precautions to wear my face coverings, to wash my hands, to wear protective equipment when I need to, and to also sometimes change my clothes. So when I get home, I'm not wearing the same shoes and those kind of things. When I go out in public, I'm washing my hands, I'm wearing my face coverings, and same thing, avoiding large groups of people. One of the other important thing is going to be that you screen your child for symptoms and you are able to keep them home if they're not feeling well. I'll be very honest with you. Right now, the patients that I'm seeing in my office, COVID-19 is not the most common illness that I see. It is more likely right now to be an ear infection or strep throat than it is COVID-19. But we know when kids go to school, it might increase that risk, and we have to do everything to keep them safe. You should notify the school if your child or someone in the family has been exposed to COVID-19 and follow a 14-day self-quarantine rule. What is an exposure? Everybody asks. So in general, an exposure is being within 6 feet of somebody who has the COVID-19 infection for more than 15 minutes without a face covering on. So in general, if you're wearing a face covering and you're within 6 feet for more than 15 minutes, you've automatically reduced that to a low risk exposure, and all you have to do is monitor for symptoms. But if you don't have a face covering on, that's when you're at risk of moderate, at moderate capacity, and that's where we recommend that you follow the 14-day self-quarantine rule. Self-monitoring for symptoms is basically, am I developing symptoms? And the main ones being fever, cough, headache, shortness of breath, loss of smell or taste. And the other thing is, if somebody in your family is ill, if it's not a COVID infection, we want them to be fever-free for 24 hours for return to school from any illness. And that's the same as it's always been. Whether you have strep throat or an ear infection, we want you to be fever-free so you're less likely to share those germs with the fellow students at school. This is the other thing that I've been doing to teach kids what we can do to help decrease their risk of any infection. And it's also interesting that when COVID-19 started in our community, we started wearing more face masks, and flu illness almost completely went away. We still had active levels of flu going on well into March and April. And as we saw people start to practice social distancing, wearing face coverings, we saw flu really go to undetectable levels, which is amazing because in Florida, we normally see the influenza virus 12 months out of the year. So we teach kids to do the 5. The first is to wear a face mask or covering. We should do this anytime we can't social distance, anytime we're in public places, and anytime where we are at risk for being exposed to the virus. The second thing is wash your hands. You should wash your hands before putting your face mask on. You should wash your hands after you take your face mask off. You should also wash your hands before you eat and anytime you touch surfaces that could be contaminated. The third thing is sneeze and cough into your elbow. And I always like to give the example of dab. I'm not cool, but I have 2 teenage sons. So if you sneeze and cough into your elbow like that, the kids enjoy that and you can teach them pretty easily. The other thing is keeping hands away from the face. All kids like to touch their face, and especially if they have on a face mask, to teach them to use it by moving the earpieces on and off their face. And the last is stay in your space and don't share food or things with your friends. And I know this seems like a contradiction because we start teaching kids to share from a very young age, but this is the exception in the time where we really want them to stay where they are and try not to share with others, because it's that mutual touching that can spread some of those viral particles. All right. Here we go. I'm sorry. Face coverings, do's and don'ts. So first of all, it's important to find a face covering for kids that fits them well. In general, kids' faces are smaller and you don't want them riding up into the eyes, so it blocks their line of vision because that can be dangerous for kids. It is important so it covers the nose, comes across the cheeks, and then actually molds to the face. If it's sticking out really far over the ears, riding up over the eyes or underneath the nose, it's not really effective in containing their respiratory droplets. The other thing is to get something that hooks over the ears or around the neck and the top of the head. Something that has to be tied isn't really useful for kids. It should be at least double layer cotton and something that's comfortable and fits well. They're going to be much more likely to be compliant with. You should teach kids to put the face covering on and off by using the earpieces. So you're actually going to loop it over the ears and over top of the nose and then sort of pull down on the outside and outer edges. I do have a mask here and I have a little face, so I have a little Mickey Mouse Donald Duck to go along with me here. So actually the easiest thing to do is pull, put over the nose, loop over the ears, and then just tuck under the chin if you need to. As you can see, a lot of them have a bendable nose piece, covers along the face, and then there's not a gap here. If there's a big gap, you can always tie the sides, and there are many, many different ways to do it on the internet that you can see. And in general, I know you can still hear me pretty well. And I wear a face covering pretty much all day long at work and an N95 part of that day. So I can tell you we can all get used to it. So the more you practice at home, the easier it'll be when kids are at school. Same thing when you go to take it off, you want to grab it by the earpieces and pull away from the face. Try to get kids not to tug on the middle of it. And when it's time to take it off, grab the outside edges and flip it inside out. That allows for only to touch the part that touched the inside of the face and not the dirty outside, and tuck it into a clean baggie or into their pocket for use at the next interval. The other part is to make sure you wash your hands before and after, and kids are used to doing that pretty much as part of their day, so that's should be easy to continue to encourage them to do so. Exposure and risk. We know in general, based on our definition of exposure, if kids are wearing their face coverings in a classroom, that the risk of exposure, even if somebody else tests positive in the classroom, is going to be low and may not keep them out of school. It may actually just be that they need to monitor their symptoms, because if everybody's wearing their face coverings, then it'll be really important that they have a low risk and that everybody else has a low risk. And then they're not missing days of school, and kids will appreciate that as well. And I think I got through that relatively quickly. So I'd said about 15 to 20 minutes. And so I'm gonna pause here and ask if anybody has any questions at this time.
You're on mute, Dr. Rohini.
My apologies. My apologies. I'm sorry. Old
It's
age has caught up with me. All right. So the CDC. So the question was, the CDC director July 8th in a press meeting said there's no data that children drive coronavirus spread. What evidence are you basing the idea that our children should wear face masks? That's the first question.
So in general, we're basing the idea knowing that it decreases the spread by 65 to 70% just by wearing those face coverings. So in general, if there is a chance that a child has contracted it from somebody else in their family, and whether they're asymptomatic or not, if they are in your classroom and they develop symptoms, then automatically everybody is considered exposed. But if they have on a face covering, or those around them have on a face covering, then automatically that risk goes down to being a low risk scenario, and there's no reason to isolate those children from their classroom setting. So really, this is encouraging kids to stay in a classroom environment where it's better for their learning and they're not taken out of that situation on a frequent basis if there's an exposure.
And there's one more question, which is, your testing is of the PCR variety?
Currently in our health system, all of our testing is PCR based. It's reverse transcriptase PCR, which is about 94 to 96% accurate depending on which test we're using. And currently, to keep our levels up to about 2,000 tests a day, we are using a combination of 5 to 7 different laboratory studies that are all based on the PCR testing. Community testing and certain centers where you can pay to be tested is actually an antigen test. It's about 80% sensitive, and it's most useful for somebody who has a low risk contact or is asymptomatic. And those that are symptomatic, sometimes we still get negative tests depending on the test sample and which test is done. But in those cases, we tend to be conservative and either retest or treat them as if they're positive based on their symptoms. Almost invariably, one of the symptoms that is only associated with COVID-19 at this juncture is loss of sense of smell and taste together. So actually one of the hospital systems is currently, instead of doing temperature screening upon entering their health system, they're actually doing a smell test.
So the other question was, and I'll take a shot at answering this one. How are we preventing kids to pass out when playing outside with masks in this Florida weather? It's super humid and hot. They need to play to develop their social skills, but I'm really worried about him passing out. When the children are playing outside, we will have a mask break. We will keep the children away from each other. I'll let Dr. Canody talk about the possibility of exposure in a play environment, but when the children are running, they will not be wearing masks. Dr. Canody, your thoughts on that?
Yeah, so in general, especially when you're in an outside environment, the chances that they're going to be standing within 6 feet for 15 consecutive minutes, it's not cumulative minutes, it's consecutive. So if they're running and playing, that risk is automatically decreased. And so that's going to be really appropriate for kids to take a mask break at that time. Additionally, if they're doing other activities where their heart rate's going up, it's strenuous exercise or it's vigorous, it is not recommended that kids wear a face mask. Kids under 2 should not wear face masks, and any children that have special needs or developmental issues such as sensory integration disorder or other sensory issues, there is some data surrounding them wearing a face shield that's clear that can be seen through, also for children receiving speech therapy. So there are exceptions to this, and those are all valid questions. But in general, outside playing, that's the time when kids are going to get a break, and we would not want to affect their breathing, especially when they're active.
So the other question was, the school has been open all summer where the kids have not been wearing masks. What has changed? So my response to that is we have not had as many children in the building. So now with Dr. Cannody's recommendations, we are requiring that all children either wear a face mask, a gaiter, one of those things that hangs around your neck and pull up, or a face shield. I know there's a question on being able to see facial expressions. What we're going to do is the teachers are actually going to be using iPads to record the formation of words and things like that. And sometimes depending on, we've got also built outdoor classrooms. When the teachers are more than 6 feet away, they can actually try and do that. I know these are difficult times, but we're going to do the best to try and keep everybody safe. The other question was, do you agree? Okay, so I'm going to leave this one. This is a longer one. Would masks for teachers that have a clear front be an option to help with more visible facial expression? The inability to read faces was a big concern of mine as well. We are requiring all our teachers to wear face masks. Some of them are wearing face masks and shields, but our teachers are required to wear face masks. The shield, from what I understand from Dr. Canody, is not enough for an adult to prevent some kind of transmission or exposure. Is that correct, Dr. Canody?
So in general, correct. Yes, if the teachers are within 6 feet of the children, then we do recommend that they have on a face mask as well. And in general, face masks protect other people from our respiratory secretions more so than you protect yourself from other people. But that can be part of those because because we don't have a wealth of data yet about schools and back to school information. We know one of the biggest risks will be to the adults in the school. So making sure that we keep them safe is an important part of keeping the school going as well. The other thing is if teachers are standing in front of the classroom and they're 6 feet away and they have on that face shield, they will be able to pull down their masks, especially with the children having masks on, so they can be able to have their words seen and work with the children. And that there should be room for that to be done on an ongoing basis as needed during the class cycle.
The other issue is the problem with letting people choose and not having a uniform policy. allows for kids to feel left out either way. We all need to do what we have to do so our kids' school is the safest place possible. I couldn't agree more. All of our children are required to wear either a mask, a gaiter, which is one of those things around the neck, or a face shield. So all children are required to wear that. We have to increase the likelihood that we increase safety for everybody. Dr. Kennedy's camera has not been off. Her camera's been on. She's been using a phone for audio. So that's, some of you may not have seen the demonstration, but we'll post this so you'll have a better chance to look at it.
I may add that we will educate the children on mask etiquette, and we are working on that as well.
Dr. Kennedy, are the symptoms the same for adults and children?
The symptoms can be similar, but in general, about 50% of children are actually asymptomatic, which is much more than in the adult population. So they tend to be more asymptomatic carriers. Children have a lot less shortness of breath, and fever and GI symptoms seem to be a little more common in children than they are in adults who develop more respiratory symptoms. But the symptoms in general are similar and include fever, cough, shortness of breath, nasal congestion, headache, diarrhea, abdominal pain, and then the decreased sense of smell or taste.
So here's another question. All the stats for kids that were presented here seems low, and that's great. But do we really know which way it will go once all the schools open? We have not really tested kids too much in the past 5 months, and most of them were at our home since March. Is there a possibility that once everyone is at school, we will see numbers rising up and see more complications? I was just wondering.
So in general, we don't have a lot of data yet to give you an absolute answer. We know that there's a risk for increased transmission based on kids being together, especially in larger schools where there's a lot more students. But we do have some data from other countries throughout the world. And then also based on our experience with summer camps and some of the summer programs that have continued through the summer, in general, those rates have been really low. And I can tell you with our own pediatric experience here with Baycare Health System, less than 1% of our patients who have tested positive for COVID under the age of 18 have been hospitalized. So out of 1,500 patients who have tested positive, we've had less than 12 hospitalized in the last 5 months, which really bodes well the kids' immune system and the ability to fight off this virus or be asymptomatic throughout the virus. We're not sure yet exactly why that is, but in general, we think it's because a certain part of their immune system works better than it does in adults. And I think that gives us great hope that kids will do well even when they're back in school. I can tell you, I sort of joke with my colleagues all the time, it's a great time to be a pediatrician because I see so many of my adult colleagues who take care of the elderly and take care of those in the hospital, and they're really overwhelmed. We have had to transform several of our pediatric units in the hospital to adult units for care to sort of make up for the difference and disparities in the numbers. So I think it's encouraging that we see less of the pediatric population, and I think that there may be some increases, but I think in general, if we follow the recommendations, that risk is gonna remain lower, especially in the pediatric population.
Dr. Kennedy, the other question is how often are the mask breaks? So how often should we have mask breaks?
I think in general, especially if kids are socially distanced, I think that, having 5 minutes where they get a break every hour sounds pretty reasonable, and kids spread out throughout the day when they're having a snack, when they're having their meals, and when they're outside, that's going to give them breaks throughout the day as well. The other part to take into consideration is when they're taking breaks, just make sure they're distanced throughout the classroom. And I think we've talked about it as well for meals, that keeping kids in the same group really mitigates the risk. So instead of having people all in one common area for lunch and for snacks, keeping them with their cohort or their class group makes a big difference on their exposure to multiple kids.
Is there a particular mask that you recommend for children?
I think it's more important to find something that's comfortable for them and something that they're actually going to wear. The problem is if you get something that's uncomfortable or scratchy or rides up into their eyes, it's a bigger issue, and sort of goes from, and that becomes a bigger concern. And I think, can you see me now? I think you can.
Yes. Yes.
Yeah, sorry, I was sharing my video screen and totally forgot about that. But I was showing in general, so I've got my little Mickey Mouse mask here. So what you're gonna do is teach them to grab it by the earpieces and sort of stretch it, hook it on the nose, and then over the ears, and then just grab from the edge. So the fit here and here and here makes a big difference. Same thing when they're taking it off, grab from the earpieces, pull away from the face, only touch the edges, fold it in half, and then they can stick it right in their pocket.
And then how many extra masks do you recommend? Should we have each of the families bring 2 or 3 masks? Do we have them in their cubby?
I think just having one per day and then having a backup would be fine. In general, kids, you know, tend to drop things or twirl them around or get food on them. And so just having a safe place to store it, a little baggie to put it in, and having a backup just in case you need it is reasonable.
And then the other question is, how are you going to enforce these young kids to wear a mask? I think we've got teachers working on videos. We're going to educate them on a daily basis about the importance of wearing masks. Constantly, some of them tend to pull it off their nose, and constantly reminding them, the teachers are reminding them to put them up over their nose. I know one of the moms said, our son just turned 3, we are having a difficult time. And then another mom came and said, well, you know, we've been practicing in 30-minute increments over here. You know, it's not an option because we have to go with Dr. Kennedy's recommendation that everybody wears masks, you know.
Awesome. Yeah, I recommend that they, yeah. And so in my office, you know, obviously since COVID began, we had to really change how we saw patients and how we brought them in and out of the office. And so we require kids 2 and over to wear them when medically possible. And they've been really great. I think kids in general do really well with structure, and they do great when you lead by example. So practice wearing them when you go out into the community, practice wearing them at home, teach them how to use them. And I think when we teach kids, hey, we're not just doing this for you, we're doing this for your friends and our family. So if you do this, you're not just taking care of yourself, you're taking care of those around you. It makes a big difference, and kids feel like they're doing something great, and they take responsibility for it. Also, let them decorate their own mask. I don't know if you're going to have a policy as far as what it looks like or any design.
No, we don't. No, we don't. Whatever they wear comfortably is good for us, you know.
But
yeah, so superheroes, princesses, bedazzle them. It's fine. It works great.
So they said that will the kids have masks, when the kids have masks on, will they be allowed to physically play with each other inside? For instance, work on a puzzle together?
We'll try and, as long as they're wearing their masks.
We'll try and keep them, you know, we've got all the tables pointing now, all the chairs pointed kind of in the same direction, and there's going to be a little bit more movement than normal.
Every child has their own work rug. So they're going to be working on their work rug. And remember, this is temporary. And for this year at least. And then, you know, this is a new normal, and we have to do it for the best interest of everybody.
And I think in general, if they're wearing masks, then for brief periods of coming together and working on things together, there's going to be those times where they need to do that. And kids are still going to be social. So at least if they've learned to wear those face coverings when they can't distance, that's really important. That's their next line of protection.
Okay, did I miss any critical question that somebody may have asked? I apologize because there were a lot of questions. So I try to answer, go through as many that came in. So, so what I'm hearing is if the children wear masks in the classroom at all times, then if one of them does test positive, it would not require the entire classroom to quarantine for the 2 weeks. Is that correct or not, Dr. Canody?
That is correct. If they're wearing their face coverings and following the guidelines that have been put into place, then the only thing that will be recommended is to monitor those children for symptoms.
Yeah. So, and then the other question, what is the plan for nap time? I can tell you this, that the children are going to be sleeping toe to toe, so that automatically puts them about 6 feet apart. And we're going to try and keep at least 3 feet between their mats. So we're going to try and keep as much distance as possible for the nap time. How about the transmission by touching the surface that has the
Oh, and
virus?
I think I see, sorry, I finally pulled up the chat. So I see I have a question. Oh, I saw a question about how many children have died in Hillsborough County from COVID-19. There's not been a pediatric death reported in Hillsborough County. We've had 5 total in the state. We did have one in Pasco County, a 17-year-old. I do not know underlying details. And then another 17-year-old down in Fort Myers that did have a chronic respiratory illness. Those are the only 2 I know in this area. The other 3 were not really on this side of the state.
How about transmissions by touching the surfaces that has the virus on it, like on the playground, Dr. Kennedy?
You know, in general, in the Florida heat, the chance that the virus is going to live for a long time is pretty low. And so I think the combination of just having kids wash their hands and when they come in from the playground and teaching them to avoid touching their face is going to be important. But in general, that's pretty low risk. I don't know if you remember when all this first started, everybody was wiping down every Amazon package that came to their doorstep and every container they brought home from the grocery store. And we really felt like, in general, those are particularly low risk at this time. And you can do it to be really thorough, but the risk in general is really low from those kind of surfaces. Same thing for outside. If you're inside the home of somebody who's actively shedding the virus, then those surfaces become more contaminated. And on some hard surfaces, the virus can live in a climate controlled environment for several days. But in general, wiping down the classrooms on a regular basis and the plans that the school has in place, we've consulted on, and they're really good information on the way that they live and the way that they practice cleaning everything at intervals.
Yeah, actually, all the high-touch areas like doorknobs and all are wiped down every hour, you know, to try and facilitate any kind of, you know, to maintain high levels of hygiene. There are a lot of compliments for you, Dr. Canody, as one of them is from a pediatric nurse practitioner and a fellow parent thanking you for your evidence-based excellence information and thanking you for taking your time to provide this information. How often will the classroom materials be cleaned?
Wipe them.
Thank you.
Time with Lysol. Right?
Yeah, so they're being cleaned on a continual basis.
Every hour.
Literally, well, not everything can be wiped on every hour, but
no, once a child uses something.
Yeah, once a child uses it before another child uses it, we are actually wiping down the materials to allow them to prevent any kind of spread or any kind of infection. Any other questions? Sorry, that was not a question.
So I just wanted to comment real quick. I know there was a comment about the 17-year-old that passed away. They're not disclosing a lot of information on any of the pediatric deaths. We do know that everybody that's passed away did have some type of underlying illness, but it wasn't disclosed what type. And so I don't want to make assumptions. But we know at this point, the risks to children who are healthy, and especially for those under the age of 10, is relatively low risk. And so putting all that together, I want to sort of put it in perspective. So flu, influenza, we've known about for decades. We have a vaccine that's been well developed and it's been around for well over 25 years. Last year in the United States, we had 25,000 deaths from influenza, and we had 200 in the pediatric population. So we're not saying we can completely eliminate the risk, but yet, despite having influenza every year, we still send our kids to school, and we know how we can prevent it, and we know how we can decrease the spread. But in general, this virus, we're learning as much as we can, as quick as we can, and we really want to weigh the risks and the benefits. but we really want to make the school a safe environment. And that's part of the purpose in educating everybody, taking all these precautions. And sometimes they seem like they're a little much, but in general, if we are saving lives, it's never too much for all of us. And for those of us on the front lines, thank all of you who follow those precautions, because we still have to go to work every day and take care of people when they get sick. And if we prevent one infection, that's one less person that we have to treat.
So the other question was, are you going to close the school if a teacher tests positive? If a teacher tests positive, we will close the specific pod, not the entire school. And that's why we are running the school as separate pods. Will the parents be informed if a child had COVID and still attending school? If a child tests positive for COVID, they need to self-quarantine at home and get medical care. They will not be allowed into the building till we get clearance from either Baycare or another health professional.
So I can
great.
give you a little guidance real quick on that. If somebody is symptomatic and tests positive for COVID, they are considered quarantined 10 days from the onset of symptoms and 24 hours until those symptoms are improved without a fever. If somebody is asymptomatic, then they are to quarantine from 10 days from their positive test, or if they are not tested and asymptomatic or exposed, then it's 14 days of self-quarantine past the date of exposure. You're muted.
My apologies. I'm saying, are there any other questions for Dr. Canody? And I think I just want to reassure the parents, we are actually going to be forming a partnership with Baycare Solutions to visit our schools at least on a quarterly basis to do a review of our health procedures, even after COVID is over, hopefully soon. But we plan to have Baycare as a major partner to ensure the safety and health and well-being of all of our children at all of our locations. Any other questions for Dr. Canody? You're working with Pinellas County Schools?
I am working with Pinellas County Schools. I've been a member of their advisory board since April. And through Baycare, both myself and an infectious disease specialist have been asked to serve on that board. And additionally, I've done a couple other smaller school consultations. And then I also serve on the COVID task force for Berkeley Prep, where my children go to school.
Well, I know we are out of time. Dr. Canody, on behalf of all of the families, all of the children, my entire team, and from Rohini and myself, I just want to express my debt of gratitude for you taking time from your schedule to do this for us. It's been very, very helpful and very informative. So thank you so much, and God bless you for doing God's work. Thank you so much.
Well, thank you for having me. You all have been a pleasure to work with. And I also want to extend a thank you to my team at Baycare, including Donna, who's our Vice President for Business Development, and Brittany, who's our Corporate Wellness Consultant. They've both been vital in playing a role with this consultation.
Yes,
so,
they've been absolutely wonderful, and Brittany's been very, very responsive. If I were you, I'd give her a promotion and a raise. So she's happy with me.
We've adopted all the safety measures which have been recommended by you. Our staff has been educated, and we'll educate our children. We are going to be Montessori strong, and we are going to overcome this.
Thank you so much, Dr. Canody. God bless everybody. Thank you. Be safe.
You're welcome. Thank you.
Thank you.